All right. Hi, everybody. Thank you so much for joining us today. I'm Sasha Kelchev-Korn. I'm Executive Director at Realm of Caring Foundation. And I am joined once again by Dr. Swathi. We're always so happy whenever she can join us and speak with our community of healthcare practitioners and our community of clients to provide us some insight. So for today, the insight is going to be on drug to herb interactions, as well as answering some of those questions that came in through our newsletter and through our socials. Dr. Swathi is co-founder and chief scientific officer at Element Apothec, as well as, and I love saying this, an award-winning pharmacist specializing in integrative health. Hi, Dr. Swathi. Thank you for joining us today.
Thank you so much for having me. I love being here and interacting with the Realm of Caring community.
Yes, well, we love having you. And I know that you have a presentation for us today. So if you are, we're going to share your screen. Please
yes,
feel free.
Let me do that right
awesome.
now.
And while you're doing that, if anybody has questions to type in, we do have that Q&A box open and we'll save some time at the end to answer those questions. So feel free to use that box.
All right, let me know if you can see my presentation full screen.
Yep, I can see it.
Okay, awesome. Alrighty, so what I will do is, kind of go through this presentation, introduce myself a little bit, talk a little bit about pharmacogenomics, and then how pharmacogenomics is important when thinking about drug interactions, in particular with cannabis. And a lot of the research we have right now with drug interactions is really based on CBD and THC, not necessarily on minor cannabinoids, so just something to keep in mind. And I'll go into that a little bit, for this presentation, but also good to keep in mind for any questions you may have. I'm happy to delve into any of the research that is out there for minors. However, most of it is in rodents, and I don't like to extrapolate from rodent or like in vitro research to really apply to humans. But I'm happy to answer any questions. And also, as Sasha and I were talking about a little bit before everyone hopped on, is some of the questions that were sent in are actually literally all the questions were so good, and really helped me direct a lot of the content I was putting together. And also because of that, decided to make my presentation a little bit on the shorter side, so we have more time to delve into and answer as many questions as possible. And as a backup, just in case we don't get to your question, I did put my email in my name. So in case you have a personal question or a question that wasn't answered on today's live, or if you're watching the recording and want to reach out, please just send me an email and I'm happy to answer questions that way too. Okie dokie. Okay, I'm going to jump right in there. All right, so I just have some learning objectives just to get started. So first I'm going to talk about backtrack. First, I'm going to talk about the concept of pharmacogenomics, and then I'm going to talk about pharmacogenomics and why it's important with major cannabinoid metabolism. So major cannabinoids meaning CBD and THC, and I kind of teed that up in the beginning as well. And then I'll talk about some of the drug-drug or drug supplement interactions, especially when it comes to CBD and THC, and you'll understand a little bit about why I'm kind of giving the background framework of genomics and talking about a little bit of the metabolism or the breakdown of the CBD or THC, so the minor cannabinoid or major cannabinoids. And then we'll jump into some of the interactions, and also happy to answer any questions about that too. And then really, the most important thing to me when it comes to pharmacogenomics or even thinking about drug-drug or drug supplement interactions, it's really all about personalized patient care or individualized care. So that's a little bit about, what we're going to be talking about today. Then a little bit about my background. So I'm an integrative health pharmacist, and I really define that as a healthcare professional who is really interested in individualized or personalized care. The fancy terminology for that is patient-centered shared decision-making, but it really takes into account what are the patient's goals and how can I, as an integrative health practitioner, help my patients achieve exactly what they want to achieve. And so I invoke any of these, possibilities or modalities that you see on the schema on the left. I, with one of my mentors, created this quite a few years ago, and I continue to update it with more modalities and different things that I think are helpful for nearly everyone. And, if someone comes to me, for example, and says, I'm having XYZ issue with sleep, I'm not getting, the right sleep quality or sleep quantity, I always use that as an example. There are so many different possibilities that I can recommend. And so it's really thinking about what's going to fit with the patient's goals and what's going to fit with the patient's lifestyle as well. And so for some people, it is talking about the incorporation of movement and sleep hygiene. For others, it's talking about which supplements, whether it's one or a combination of them, could be a good choice. Some people are on quite a few supplements and quite a few prescription medications. And so for them, it's actually thinking about, what can we incorporate into their daily life that is not going to have any drug-drug or drug-herb interactions. And, the main, crux of really what I do is thinking about the benefit versus risk ratio. And that's something I'm going to be talking about quite a few times. And it's going to come up pretty often today, because it's really thinking about, if I'm going to add, like, let's say cannabis, or if I'm going to add CBD or THC into my regimen, is the benefit going to outweigh the risk with all the other factors involved in the patient's life, inclusive of their prescription drug regimen, their supplement regimen, their herb regimen, and, anything else that could really play a role in the breakdown or the metabolism of these items. So first, we're going to talk a little bit about pharmacogenomics. So to understand pharmacogenomics, we also need to talk about what's called a therapeutic index. And a lot of the drugs that you'll see that I'll talk about later, but also in general, that are known to have, really, really high levels of drug interaction. So that means that they could potentially interact with a lot of different other drugs, meaning prescriptions, or they could also interact with other supplements or herbs. Oftentimes they have what we call a narrow therapeutic index. And so as you can see on the graph on the left side, you see a therapeutic index. It's really this amount of space when we're looking at the dose and the percentage of people affected between the therapeutic effect and the toxic effect. And so the therapeutic index is going to vary as in how large this index is per patient, but the drugs that have the least amount of drug interactions have wide therapeutic indices, versus the opposite, drugs that have what are called a narrow therapeutic index, like some we'll talk about later, where the therapeutic effect and the toxic effect are, like maybe a few milligrams away from one another. Then that becomes more of an issue. And then we have to think about, okay, how is this drug broken down in the system? And what other drugs are being broken down in a similar way that could interact with the process of the way that the drug is working in the body? So I hope that makes sense, just to provide context that, the drugs that tend to have more drug interactions, the therapeutic index between the therapeutic effect and a potentially toxic or bad effect of the drug is actually much smaller. And so that's why dose titration is so important, especially when it comes to cannabinoids, because we want to increase the dose as slowly as possible to see what type of therapeutic effect we can get without reaching any sort of toxic effect. And toxic in this context could be just unwanted effects, like maybe we're taking too much of the THC and therefore, we're either having psychotropic effects or we're just getting extremely sedated. So maybe that's, kind of more on the edge of what we don't want, but we want closer to the therapeutic effect or the benefits that we're actually looking for. So some of you might already know this information, but I wanted to give it again as a framework as we continue the discussion. So THC and CBD are the two major cannabinoids. As I mentioned earlier, a lot of the research with drug-drug and drug-herb interactions in general, when we're thinking of cannabinoids, are kind of focused on these two cannabinoids. And we don't have as much information about minor cannabinoids. And so the most important information on this slide for our discussion today is when we think about, let's say we're ingesting THC, how is THC broken down in the body? And if we understand how it's broken down in the body, then we understand, okay, these are the type of effects it's going to have. So it is partially, yes, what receptors it binds to, but it's also partially, what is actually the enzyme or the protein that's breaking it down. So as you can see on the left side, THC is primarily metabolized or broken down by CYP2C9, 2C19, and 3A4. These are three different types of enzymes that are all a part of this CYP or CYP family of enzymes. And as you can see with CBD on the right side, it's primarily broken down by 2C19 and 3A4. And you might see some overlap here, right? Because THC and CBD are both primarily broken down by two of the same enzymes, so 2C19 and 3A4. But in addition, THC also has quite a bit of metabolism or breakdown by 2C9. And so this is really important to think about because a lot of the drug interactions that we will talk about tonight, and a lot of the drug interactions in general, really come down to, okay, if they're broken down, let's say CBD and THC are broken down by these particular enzymes, what else is the patient taking, or what else is the patient interested in taking, and how is that particular item broken down? Because if they're broken down by some of the same enzymes listed on the screen, then it's possible there could be a drug interaction. And in particular, when we're thinking about the pharmacogenomic impact, or really just, what type of metabolism is the most important that could have some sort of pharmacogenomic effect, it comes down to the way that the dose is administered. And so because, like, for example, with inhalation, it bypasses what we call first pass metabolism. So first pass metabolism means that, once you're inhaling something, it's not going through the entire gut process. It's not entering, the gastrointestinal tract. It's not going through the colon. It's not going and getting broken down by the liver in that way. And so there's very little CYP450 involvement, which is very important because, a lot of this discussion is, yes, we're talking about the breakdown or metabolism of CBD and THC, and we're talking about it in the context of these enzymes. But these enzymes are not as involved if there's inhalation. Where they're most involved is in oral formulations, because it has to go through this first pass metabolism. And most of the CYP450 enzymes are actually involved in the gut path or the first pass metabolism. Specifically, they are involved in liver metabolism. And so most of the CYP450 enzymes that you'll see are found in the liver. And if the product that you're consuming, the active ingredients, are being consumed orally, they're going through the entire gastrointestinal tract, and therefore a lot of it is going to be broken down by these CYPs, or by these enzymes. And so, as I mentioned, the CYP family is quite a expansive group of different enzymes. And I mentioned before, THC is broken down by the blue one, so CYP3A4, as well as 2C9 and 2C19. So they're kind of the lighter two orange sections. And then CBD is primarily metabolized by 3A4, so the big dark blue one, as well as 2C19, or the lightest orange one. But as you can see, this graph actually shows us all of the different drugs that are on the market right now and how they are broken down. So about 30% of the drugs on the market are broken down by CYP3A4. So this means that potentially there could be upwards of 30% chance of a drug interaction with CBD or THC with another drug or supplement someone is adding to their regimen. Very fascinating. Of course, we'll talk about a few factors, that I have listed here that play a role in whether or not this 30% is actually going to impact the patient in a negative way. And something that we're not going to have a chance to talk about today, unfortunately, but the idea of a drug interaction doesn't have to be positive and doesn't have to be negative. So for example, when people think of drug interactions, they think, oh my goodness, a drug interaction is bad. Not all drug interactions are bad. So let's say someone is taking a drug that's metabolized by CYP3A4, and they're also taking CBD. For example, a great example is passion flower. Passion flower is metabolized by quite a few enzymes, inclusive of CYP3A4. And so if you put it through a drug interaction checker online that looks at herbs and cannabinoids, it will come back flagged saying, oh no, drug interaction. But really, if you read about the drug interaction, it says that the drug interaction involves sedation. And you might see a lot of formulations out there that have CBD and passion flower And lavender also can fall into the 3A4 bucket. And so even though, yes, there is this chance of this 30% drug-drug interaction, we need to reframe what we think about with a drug-drug interaction, that not all of them are bad. And so if we're looking to take a product that has CBD, that has lavender, that has passion flower, they might all be a great option together because they synergize to promote better sleep quality and sleep quantity, versus, thinking about it in a negative way. But then there are some opportunities and situations where it's going to be a negative interaction, where this one drug gets in the way of the breakdown of a cannabinoid, or a cannabinoid gets in the way of a breakdown of a supplement or a drug or an herb. And I'm going to get into a little more detail about that. But I didn't have a chance to include that in this presentation, the idea of positive versus negative drug interaction. So I wanted to at least include a little tidbit about it here, and I'm happy to answer any questions about it. And, enzyme activity, as I mentioned, these are all enzymes listed on the screen. They can, have a lot of different factors that play a role in the way that they work. Genetics or genomics is something we're talking about a little bit, very, very soon. And then also things like lifestyle, smoking, and other diseases can also play a role. And so it really depends on a lot of factors, and therefore personalized medicine is really key. And so if we're thinking about, drug metabolism, we have to think about it right in the context of these enzymes that are breaking down the drugs. Once the drugs are broken down into smaller components, then they can exert their, benefit, or, their intended effect in the body. And so if we break down the pharmacogenomic differences between drug metabolism, we're thinking about, okay, there are 4 different types. And most people are what are called immediate or slow metabolizers, or they're called extensive metabolizers. I would say probably the average person is an extensive metabolizer. This means that you have no issues in your gene variants of these enzymes, and you have optimal functioning. I'll explain a little bit more about what that means, but the average person, I would say the average person is an extensive metabolizer, meaning that they don't have any gene variants. Again, saying like that you're average or not average is not a bad thing or a good thing. It's just really important to understand that for the way that you break down certain drugs. And in this case, certain cannabinoids, because for each enzyme type, so for example, we have CYP3A4. I keep using this as an example because it's like one of the most common enzymes, as you can see even from the chart, that break down a lot of medications and drugs and herbs on the market right now. Upwards of 30%. I've seen percentages even higher than that, honestly. And so for each of these enzymes, let's say for CYP3A4, everyone has CYP3A4 enzymes. Most people are extensive metabolizers. So that means they have optimal functioning. You put the drug in the body, it comes out in the intended effect for the average person. However, some people, like 10% of people, are called poor metabolizers. And then some people are intermediate or slow metabolizers. So there's actually quite a lot of people that fall into that category with upwards of 50%. And then there's also the remaining population that's an ultra rapid or rapid metabolizer. And I'm going to talk a little bit. Let me see. Oh, I'm not going to talk about, I took out a few of the slides to make sure we have time for questions, but let me give an example. So, let's say for CYP3A4, I am an intermediate to slow metabolizer. This means that I have one gene variant and I have less than optimal effect. So that means if I'm a slow metabolizer, think about it in this way. I'm ingesting 10 milligrams, let's say, of CBD. If I'm a slow metabolizer for my CYP3A4 enzyme, that means I have one gene variant and therefore I have less than optimal effect. So less than optimal effect means that it doesn't function as well as it should. So the goal of an enzyme is to break down something or metabolize something. If the enzyme is not working as efficiently, that means it's going to take longer for the enzyme to break down CBD, and therefore longer time for me to have an active effect from it. So for someone who's a slow metabolizer, I would recommend that, they take less of the medication, because over time, it takes longer for the actual medication to have an effect on the body. So you don't want to overwhelm the system and then not get the effect you're looking for. Whereas for the ultra rapid metabolizer, there are people who have 1 to 2 variants and they are metabolizing so quickly that you might have to give this person 2 or 3 or 4 or more times the amount of dosage. So let's say the extensive metabolizer takes 10 milligrams. The slow metabolizer, I would recommend maybe take 5 milligrams for the same effect. And the ultra metabolizer, maybe I want to suggest they take 40 milligrams because their enzyme is working in hyperspeed. So they're getting rid of it out of their body so much quicker that they need to take a little bit more to actually have any kind of benefit. So this is why understanding your pharmacogenomics or your genetics in the context of drug metabolism is really important. And I think that's what leads a lot of people to get really frustrated with trying certain cannabinoid products and realizing that, oh, like what's working for, my significant other or my daughter or my aunt, they're using such different dosages. And partially, yes, everyone's endocannabinoid system works differently, which is very true. But there is this component of genetics that's really important. And like oftentimes people are not doing genomic testing. And I really wish that this was the standard because I think it would eliminate a lot of frustration in the entire dosing of the cannabinoid world, because some people will start off and say, okay, I'm going to take 10 milligrams and then feel nothing. And then maybe if they did a genomic test, they realized, oh my goodness, I'm a rapid metabolizer. I probably need to take, 4 times as much to feel the same effect. And so it's nothing we can guess on necessarily. The way to really get the quantifiable effect and look at how each of these enzymes are functioning and whether, these genomic tests will tell you whether you're a poor metabolizer, an ultra rapid metabolizer, or just a normal extensive metabolizer. And again, just because you're one or the other doesn't make you better or worse than anyone else. It's just our genetics, just the way that it is. And so the more information we have to personalize our therapy, the better we're going to feel and the better effects that we're going to have. Alrighty, so that's what I wanted to say about the importance of personalized medicine and pharmacogenomics specifically. Now I'm going to hop into a little bit about interactions and the way that I think about interactions. I came up with this terminology, so if it doesn't make a lot of sense to you or you think it's weird, then I apologize. But hopefully I can get it across to you and maybe we can explain it in a different way after the session. So mainly when we're thinking about drug interactions in the context of CBD or THC, we're thinking about the left side, so the pharmacokinetic interaction. So this is what the body does to the drug. Again, the body does to the drug, meaning how the body is breaking down or metabolizing the drug. So that's everything with the enzymes I was talking about before. The enzymes, the 3A4, 2C9, 2C19, those are the enzymes that primarily break down THC. And then we have 2C19 and 3A4 for CBD. So in this context, cannabinoids can either function as what I refer to as a prey or a predator. So this means either in these interactions, either cannabinoids can alter the serum concentration of another drug, or other drugs can come in and alter the concentration of cannabinoids. And if these serum concentrations are changed, then we're going to have different benefits than we anticipate. So I'm going to jump into a few examples here. So these are some examples of how cannabinoids act as a prey in drug-drug interactions. Again, going back to my definition, prey is when cannabinoids are altered by other drugs. So that means if you have, these are just some examples, but if you have some of these, this was taken from a textbook in case you're wondering, some of these examples, it says specifically 3A4 and 2C9. If you remember what I was talking about earlier with which are the primary enzymes that break down THC, these are two of them, 3A4 and 2C9. So this is specifically about a study that they did looking at the breakdown of THC and these two particular enzymes. And so they found that in this case, cannabinoids act as a prey in drug-drug interactions, meaning that other drugs are coming in and they are decreasing the concentration of cannabinoids, therefore they're decreasing the effects of the cannabinoids. And so this can be a problem, right? And so this is just something to consider that, whether, cannabinoids are taken with some of these medications, it says the impact on the screen. So, if they're taken with ketoconazole or verapamil, for example, or protease inhibitors, there's a possibility that there's more THC floating around in the body, and therefore there could be more adverse effects. And so all of these conversations are all just really important to think about, that cannabinoids can either influence other drugs that are being taken, and that's one way of thinking of a drug interaction. And then in this context, how can other drugs impact the concentrations and therefore effectiveness of cannabinoids? And then the opposite, of course, and then so I just gave both examples, the prey and the predator. And so that is the prey and the previous slide. The predator is when cannabinoids are coming in and acting as the one who is affecting serum concentrations of other medications. And so, if you think about it, both are bad, right? Because if you are incorporating cannabinoids into your drug regimen, there's a reason why you're on those drugs. There's a reason why you're taking other supplements. And you really want to think about, you don't want a cannabinoid to be a prey or a predator in this scenario, ideally. You do not want either of these things, because if a cannabinoid is coming in as a predator and decreasing serum concentrations of drugs that you need for other ailments, or if cannabinoids are acting as preys and other drugs are coming in and decreasing the effectiveness of cannabinoids, that's also a problem. But see, the difference is with prey, at least if we know this as the healthcare professional involved in your care, then, especially if you're working with a medical cannabis specialist, if they see that, cannabinoids in this context can be a prey, that means that, the serum concentrations or the effectiveness of cannabinoids are lower, which means that maybe we up the dose for cannabinoids in this context, right? So that makes sense, because if they're coming in and other drugs are coming in and decreasing the effectiveness of cannabinoids, let's up the dose of the cannabinoids a little bit so we get the intended benefit, because the drugs are not being impacted at all. The drugs are just doing their, like happy dance and living their life. But cannabinoids in this context are the ones that are falling prey to the situation. So there's a way around the prey scenario. When it comes to the predator scenario, there's not really a way around it, unfortunately, because if cannabinoids are coming in and decreasing the effectiveness of other drugs, but we're on these drugs for very specific, disease states or reasons, then in this case, I oftentimes say that predators, when cannabinoids act as predators, they really shouldn't be incorporated into drug regimens. And instead, we should look at other herbs and supplements that could be a better choice, because I don't know if you've heard this before, but I personally don't think cannabinoids can save everything and fix everything. But I do think cannabinoids can be incredible for so many different things. It just has to be viewed from a personalized approach. And we have to think about, is the benefit going to outweigh the risk for this patient? And when cannabinoids act as predators and mess up some of the functionality of these drugs, in my opinion, the risk outweighs the benefit, and maybe it's not the right choice. Specifically, I'm talking about the bolded red drugs on this list, where to me, the risk outweighs the benefit. Warfarin is an anticoagulant or a blood thinner. There was a great question that came in about blood thinners and CBD and THC, or cannabis in general. For the person who asked that, I apologize. I was going to say I didn't remember your name, but I don't think I got the name. So either way, so for the person who asked about blood thinners, the other terminology for that is anticoagulants. And so if a patient is on an anticoagulant, there's so many different kinds of anticoagulants. So CBD and THC can be safely taken with a lot of blood thinners or anticoagulants. The one that it absolutely cannot be taken safely with is warfarin. And you might be wondering why. Like why warfarin and not the other ones? So warfarin is a very old drug. It's still used very frequently because it's highly effective. But the only thing to keep in mind is that if you think about the first slide that I showed, I was talking about therapeutic index. All of these bolded drugs have extremely small therapeutic indices. And so if we're adding cannabinoids and cannabinoids are acting as predators and decreasing these concentrations in the body, or not even necessarily decreasing, they could be increasing, they're just changing the concentration for the worse, then that could be a huge problem for the patient. And so that's like one of the main ways to think about, okay, does this drug have a narrow therapeutic index? Is it metabolized by similar enzymes as CBD and THC? If so, perhaps this is not the right choice for this patient. Again, it's extremely individualized, and it's really important to work with, your healthcare team, bring in a medical cannabis specialist, and really think about this holistically, because I do think that cannabinoids can be so beneficial and amazing for so many things, but we always want to think about the benefit versus risk ratio. And that's honestly the most important thing when thinking about adding or subtracting anything from a regimen. So I hope that made it a bit more clear. And then cannabinoids in drug-herb interactions, I did talk a little bit about, this was also where I wanted to hit on the idea of negative versus positive interactions. So for sedation, I said passion flower and lavender before. Other examples are hops, valerian, and reishi. And these are just, some examples of things that, could be used in concert or in combination with cannabinoids, and in ways that, like, I don't have a big issue with drug interactions because most of them are not metabolized by the same enzymes. This was just to demonstrate that these are examples to me of mostly, except the red one, mostly synergistic or positive interactions. So if you look on a drug herb checker, as I mentioned before, and you look at hops, valerian, reishi, CBD, passion flower, lavender, you put them all in, it's going to come back with a huge red flag saying, oh my goodness, it's going to increase sedation. But maybe that's the goal, is to increase sedation through a sleep formulation. Or, for example, there might be something where you put in ashwagandha and chaga and cordyceps and CBD, and it will say something about immune function. And it's like, yes, but like this improves immunity and it actually is nootropic. So this is a good thing. So sometimes not all interactions are bad interactions, but it's just something to keep in mind that if you look at general checkers online, they might come back with a flag, but always read what is the exact interaction, because sometimes it's actually a good thing. And then the one red bolded one that I have on here, again, just as on the other slide, the red bolded ones are bad interactions that 9 times out of 10, I'm going to say, no, do not take this drug or supplement with cannabinoids because the risk outweighs the benefit. But St. John's wort is notorious. St. John's wort is like, this is, okay, maybe I shouldn't say that's confusing, but I was just going to say, it interacts with everything. So the only way that I think St. John's wort is a good mechanism or a good inclusion for someone in their regimen is if you are literally not taking any drugs or any supplements, then I think it could be a good choice. But with cannabinoids, with most things, it's a problem because it's metabolized by almost every single enzyme. Yeah, it's crazy. So that would be my only thing, is like, please don't take St. John's wort and cannabinoids, because that could definitely do more risk than benefit. That being said, if you are interested in St. John's wort and you're not taking any other drugs, any other supplements, any cannabinoids, St. John's wort has amazing benefits for mild to moderate depression and for anxiety. So don't think just because it's in red, it's horrible. Like, there still are potential benefits to it, just not in the context of most drugs, inclusive of cannabinoids. So this is just a summary, but it's really talking about that, drug interactions can be positive and negative, and always think about what you are adding to your regimen, because just because it's natural doesn't mean it's safe. So just make sure and have someone in your corner, whether it's a medical cannabis specialist or it's a, integrative health, practitioner who can really help you through this, because I really think healthcare professionals are the ones that are going to make the, charge, especially working with their patients to change some of these discussions and incorporate things like genomics and actual, personalized options. So that's all I had.